welcome to the deep dive. Today we're tackling a genetic condition that's actually, well, surprisingly common, hemochromatosis. Think of this as your sort of rapid-fire guide. Really useful if you're, say, a medical professional needing a quick review, or maybe it runs in your family, and you just want the key facts.
Exactly. We've taken the core info from detailed MSRA revision notes, that high-yield study stuff for doctors, and we're aiming to boil it down.
Yeah, make it clear, make it stick. Our mission is basically to pull out the essentials for understanding and revision.
Right. It sounds complex, maybe, but we'll break it down, make it digestible, add some memory aids along the way.
Okay, let's jump right in. What's the core definition? What is hemochromatosis?
Simply put, it's a genetic disorder where your body just absorbs too much iron from your diet, way more than it needs.
Okay, too much iron.
And this extra iron then gets stored, deposited really, in various organs. And over time, that buildup can cause some pretty serious damage. It's like your body's iron filing cabinet is just overflowing.
Right. And what's the genetic side of it? How does that work?
So it's an autosomal recessive condition. You remember, recessive generally means you need 2 copies of the faulty gene, one from each parent, to actually get the condition.
Okay, 2 copies.
The main gene involved is called HFE. It sits on chromosome 6. And mutations in this HFE gene lead to a deficiency in a hormone called hepcidin.
Hepcidin, right.
Yeah, and hepcidin is basically the gatekeeper for iron absorption. So if you have less hepcidin, the gates open wider and more iron gets into the body.
Ah, okay. So someone could carry one faulty gene, be a carrier, but not actually have the condition. That makes sense why it might be more common than we realize.
Exactly. And initially, people often don't have any symptoms at all. It's asymptomatic for a while.
So no obvious signs at first.
Not usually. When symptoms do eventually creep in, they can be really vague. Things like feeling constantly tired, that's lethargy, or just general joint pain, arthralgia we call it.
Yeah.
Stuff that's easy to put down to other things.
Yeah, you just think you were run down or getting older.
Precisely.
So where does this extra iron cause the most trouble? Which organs are we talking about?
Well, the primary target where it tends to accumulate first is the liver, but it also significantly impacts the heart, the pancreas, which, makes insulin and various endocrine glands, the ones that produce hormones.
And just how much extra iron are we talking about? You said it's an overload.
It's a massive overload. So normally the body has about 4 grams of iron in total. In someone with hemochromatosis, this can shoot up to like 20 to 60 grams.
Wow, 20 to 60 compared to 4. That's huge.
It really is a major difference.
You mentioned primary and secondary causes earlier. Can you just clarify that distinction?
Sure. So primary hemochromatosis, that's also called hereditary hemochromatosis, that's the inherited genetic disorder we're focusing on today, caused by those HFE gene mutations. Secondary iron overload is different. It happens because of other reasons, like needing lots of blood transfusions for another medical condition, or sometimes certain chronic liver diseases can cause iron to build up. But for this deep dive, we're really drilling down on the primary hereditary type.
Right, so the etiology, the cause, it really comes down to those genetic mutations affecting iron absorption.
Pretty much, yeah. Hereditary haemochromatosis, the common form, is all about those HFE gene faults messing up the body's iron regulation, leading to too much iron coming in from your food.
Okay, so HFE gene, chromosome 6, autosomal recessive, good genetic basics. What about the specific mutations? Are there key ones to know?
Yes, definitely. The 2 most common mutations in the HFE gene are called C282Y and H63D.
C282Y and H63D.
Right. And the C282Y one is particularly common in people of white European background. And remember, for the classic form of the condition, you usually need 2 faulty copies, either 2 C282Y copies, making you homozygous, or 1 C282Y and 1 H63D, which is called being a compound heterozygote.
Okay. And you mentioned rarer forms, too. What are they briefly?
Yeah, there are a few less common inherited types. There's juvenile hemochromatosis, which shows up much earlier, often in teens or 20s, and tends to be more severe.
Oh, okay.
There's also African iron overload, seen in people of African descent, sometimes with different genetic links. And neonatal hemochromatosis, that's rare, but very serious, causing severe liver damage in newborns due to massive iron overload right from the start.
Right, very serious. Okay, so moving on to risk factors. Who is most likely to get this hereditary hemochromatosis?
Well, the biggest risk factor by far is having a family history of it, especially if your ancestors came from Northern Europe. We're talking particularly people with Celtic origins, Irish, Scottish, Welsh, Breton.
So that specific ancestry is a major clue.
It is. That's where these HFE gene mutations are found most often. Think of it like a geographic concentration.
Interesting. Are there other things that might increase the risk, maybe push someone with the genes towards problems?
Well, genetics is the main driver, but yes, drinking excessive amounts of alcohol isn't good for anyone's liver, but it can definitely worsen the liver damage from iron overload. And having certain other liver diseases already might also exacerbate things.
Okay, so the faulty genes mean more iron gets absorbed. But what actually happens inside the body, at the cell level, that causes the damage, the pathophysiology?
Right. So when the HFE gene isn't working properly because of these mutations, it messes up the body's ability to sense how much iron it already has. The gut basically keeps absorbing iron like there's a shortage, even when there isn't.
So it loses the off switch.
Kinda, yeah. This leads to iron building up inside cells. And this excess iron, it's not inert. It triggers harmful chemical reactions, leading to something called oxidative stress.
Oxidative stress, right? I've heard of that, like free radicals.
Exactly, an imbalance between free radicals and the body's antioxidants. This oxidative stress damages cell components, proteins, lipids, DNA, and causes inflammation. Over time, this chronic damage and inflammation leads to scarring and organ dysfunction in those places where the iron builds up.
And you said the liver is usually the first stop for this excess iron.
That's correct. The liver acts as the primary storage depot initially. So, sustained iron overload there can lead to inflammation, then fibrosis, which is scarring, and eventually, potentially, cirrhosis, which is severe, irreversible scarring.
Okay, that clarifies the damage pathway. Now, thinking clinically, if someone comes in with symptoms that could be hemochromatosis, what else does a doctor need to consider? What's on the differential diagnosis list?
Ah, yes, the differentials. Super important. You absolutely have to think about other things that can cause iron overload or similar symptoms. Broadly, you can group them. There are other chronic liver diseases, certain types of anemia where iron isn't used properly. We call those iron-loading anemias, and then other secondary iron overload disorders, like from transfusions.
Okay, the list in the notes looks pretty long. Can we break down some specific conditions that might get confused with hereditary hemochromatosis?
We can try. So first, within HFE-related conditions, you've got the classic type 1 that's being homozygous for C282Y, 2 copies,
Right.
or being a compound heterozygote C282Y H63D. Then there are actually rarer defects within the HFE gene itself that can cause it.
Still HFE, but different faults.
Yeah. Then you move to non-HFE-associated hereditary hemochromatosis. These are caused by mutations in other genes involved in iron control. Genes with names like hemojuvelin, Hepcidin itself, transferrin receptor 2, ferroportin, they're all part of that iron regulation network.
Okay, so different genetic pathways leading to similar iron problems.
Exactly. And then there's a whole bunch of other often rarer hereditary things. Hereditary hyperferritinemia cataract syndrome, which is kind of what it sounds like, high ferritin and cataracts, hemoxygenase deficiency, that neonatal iron overload we mentioned.
Wow, okay.
Ceruloplasminemia that involves a protein that handles copper and iron. Problems with transferrin, the main iron transporter, that's atransferrinemia. And even defects in the transporter that gets iron into gut cells, the DMT1 gene. It's quite a list.
It really is. What about the non-genetic, the acquired causes you mentioned?
Right, the secondary causes. Think about those iron-loading anemias again. Conditions like thalassemia syndrome, sideroblastic anemia, myelodysplastic syndrome, congenital dyserythropoietic anemia. Essentially, conditions where red blood cell production is faulty and iron builds up, partly because the body tries to compensate, and often because of transfusions, too.
And transfusion overload itself.
Yes. Parenteral iron overload, getting iron from outside sources, usually blood transfusions, is a common cause of secondary overload.
Okay. And are there other conditions that don't necessarily involve major iron overload but might just have overlapping symptoms, like fatigue or liver issues?
Absolutely. You've got to consider things like metabolic syndrome,
Yeah.
the cluster of obesity, high blood pressure, insulin resistance that can sometimes raise ferritin levels, drug toxicity affecting the liver, chronic kidney disease needing hemodialysis, and of course, other primary liver diseases, viral hepatitis, alcohol-related liver disease, fatty liver disease, or NASH, cirrhosis from any cause. These can all mess with liver tests and sometimes iron studies, and even skin conditions like porphyria cutanea tarda or other causes of skin pigmentation like Addison's disease might need to be ruled out depending on the picture.
It's a broad differential then. You need to be quite systematic.
You really do.
So let's talk about how common this actually is, the epidemiology. You said it's surprisingly common, especially in the UK.
Yeah, it really is. In the UK, hereditary haemochromatosis is one of the most common genetic disorders we know of. The estimated prevalence is around 1 in 200 people.
1 in 200. That's quite high for a genetic condition.
It is. And if you look at people of European descent more broadly, maybe about 1 in 10 carry one copy of the common mutations.
1 in 10 carriers.
Yeah, and then having two copies leading to the condition affects about 1 in 200 in that population. Just to give context, it's actually more common than cystic fibrosis.
Wow.
And specifically within the UK, as we mentioned, it's most common in people of Northern European, sort of Caucasian descent. That 1 in 200 figure is a good estimate for that group.
That really drives home why awareness is important, especially if you have that ancestry. Okay, so what signs and symptoms, the clinical features, should make someone or their doctor suspect haemochromatosis?
Well, the symptoms often creep up slowly as the iron builds up over years, even decades. Common ones include that persistent fatigue we mentioned, joint pain often starting in the small joints of the hands, like of the knuckles, sometimes abdominal pain, and often a noticeable drop in libido or sex drive. In more advanced cases, you might see changes in skin color, a kind of bronze or grayish tint, sometimes called Blonde's diabetes, if they also develop diabetes from pancreatic damage.
What about the really early signs? Any clues we can use as memory aids? I saw one in the notes. Early ironing.
Ah, yes. Mnemonics can be helpful. Let's see. Exhaustion, aching joints, especially hands, reduced libido, liver may be slightly enlarged, yawning from the fatigue, irritability sometimes, right upper quadrant discomfort where the liver is, often missed because it's vague, non-specific symptoms. How's that?
That's great. Captures those early subtle things. Exhaustion, aching joints, reduced libido. Those seem key.
They really are. Persistent fatigue, that hand arthralgia, and erectile dysfunction in men can be really important early flags.
And as the iron deposits grow in specific organs, what other signs might appear?
Well, on examination, a doctor might feel an enlarged liver hepatomegaly. If it's progressed, there might be signs of cirrhosis, like fluid retention or jaundice, though hopefully we catch it before then. Imaging might show the iron deposition. If the heart's involved, you could get symptoms of heart failure, breathlessness, ankle swelling. The hormonal effects, hypogonadism, can cause loss of libido, erectile dysfunction, irregular periods in women. And that arthritis, again, often characteristically in the hands, particularly the second and third knuckle joints.
Any brain or mood symptoms?
Yes. In more advanced or untreated cases, people can develop neurological or psychiatric issues. Things like memory problems, mood swings, irritability, sometimes even depression.
It sounds like because it starts so vaguely and progresses slowly, getting an early diagnosis must be a real challenge.
It absolutely is. The long asymptomatic phase is the main issue. That's why being aware of those risk factors we discuss male gender, men tend to show symptoms earlier than women because they don't lose iron through menstruation. Caucasian ethnicity, a family history, and often presenting in middle age when the iron load becomes significant, these should raise suspicion.
Okay, so if we do suspect it based on risk factors or symptoms, how do we actually confirm the diagnosis? What investigations are key?
The whole diagnostic approach really stems from knowing it's genetic, leading to that excess iron absorption. So the tests focus on two things: measuring the amount of iron in the body and looking for those specific HFE gene mutations.
What are the first tests usually ordered?
Typically, we start with blood tests. Serum transferrin saturation, often called SAT, is a really useful one. It measures how much of the main iron-carrying protein, transferrin, is actually loaded with iron. A high SAT is a key early indicator.
Okay, SAT first.
And serum ferritin levels? Ferritin reflects the body's total iron stores. But it's important to know ferritin might be normal in the very early stages, even if SAT is high. And ferritin can be raised by lots of other things too, like inflammation.
So SAT is maybe more specific early on.
It can be a better indicator of increased absorption, yes. Ferritin tells you more about the total storage. And then crucially, genetic testing for those main HFE mutations, C282Y and H63D, is now pretty standard if suspicion is high.
Should everyone be screened for this, given how common it is?
That's a tricky question. Routine population screening isn't generally recommended right now, mainly because many people with the genes never actually develop significant iron overload or health problems. That's the issue of low penetrance.
Ah, right. Not everyone with the genes gets sick.
Exactly. But if someone has unexplained symptoms like fatigue, joint pain, maybe abnormal liver tests, then checking SAT and ferritin is definitely warranted.
And what about specific situations, like someone with liver disease.
Yes, genetic testing for HFE mutations should certainly be considered if someone has unexplained chronic liver disease, especially if their SAT is also high, or in conditions sometimes linked to it, like porphyria cutanea tarda, or even sometimes when investigating liver cancer, hepatocellular carcinoma.
And what if you know hemochromatosis runs in your family? What should relatives do?
For first-degree relatives, so brothers, sisters, parents, children of someone diagnosed, genetic testing is definitely recommended. Siblings have a 1 in 4 chance of having inherited both faulty genes if the parent had them. We'd usually test their ferritin and SAT levels as well.
Okay, back to the iron tests, SAT and ferritin. Anything important about doing or interpreting them?
Yes, for transferrin saturation, it's really important the blood test is done fasting. Non-fasting levels can be misleadingly high. A fasting SAT above, say, 45% in men, or maybe 35–40% in women, is usually considered elevated and needs investigating.
Fasting SAT, got it.
And ferritin, as I said, is sensitive for iron stores, but not very specific. Inflammation, infection, liver disease, alcohol, metabolic syndrome, lots of things can push ferritin up. So you can't diagnose hemochromatosis on a high ferritin alone. You need the whole picture, especially the SAT and genetics. Relying just on serum iron level isn't enough either.
So what other blood tests might help sort things out, maybe rule out those other causes of high ferritin?
Good point. We'd often check an inflammatory marker like CRP, C-reactive protein. If that's high, it suggests inflammation might be raising the ferritin. Liver function tests, especially ALT, alanine aminotransferase, are crucial to check for liver inflammation or damage. We might also look at general things, blood pressure, BMI, blood glucose to check for metabolic syndrome components. And depending on the symptoms, maybe other liver tests or even hormone tests if hypogonadism is suspected. Plus, tests to exclude common causes of abnormal liver function like viral hepatitis or alcohol misuse.
Okay. When do you need to go beyond blood tests, like biopsies or scans?
Well, if the SOT is high and ferritin is also high and it's not explained by other things, the next step is usually that HFE genetic test for C282Y and H63D.
Right.
If someone comes back homozygous for C282Y, meaning they have 2 copies, that's usually enough to diagnose HFE haemochromatosis, assuming they have biochemical evidence of iron overload too. Liver biopsy used to be standard, but now it's often not needed for diagnosis if the genetics are clear.
When would you do a biopsy then?
Maybe if the genetic tests are inconclusive or if the iron levels are extremely high, particularly ferritin over 1,000, and you really need to know the degree of liver scarring, the fibrosis stage, that can influence prognosis and management.
And what about MRI?
MRI, specifically a liver MRI protocol designed to measure iron content, is really useful. It's non-invasive and can quantify how much iron is in the liver and sometimes other organs, and can also help assess for fibrosis.
Okay, so interpreting those genetic results, how much risk does each combination carry?
Okay, so C282Y homozygotes, C282Y, C282Y, have the highest risk of developing significant iron overload and symptoms. It's not guaranteed, especially in women, but the risk is substantial.
Right.
Compound heterozygotes, C282Y, H63D, have a moderate risk. They can develop iron overload, but it might depend more on other factors like alcohol intake, diet, maybe other genes.
Okay.
H63D homozygotes, H63D, have a much lower risk. They usually only develop significant iron overload if there are other contributing factors present.
You're just being a carrier of one copy.
Being heterozygous for C282Y, just one copy, rarely causes significant iron overload on its own. Same for being heterozygous for H63D, very unlikely to be clinically important regarding iron. If someone has clear iron overload but tests negative for these common HFE mutations, then you have to think about those rare genetic forms or secondary causes.
Got it. And you mentioned ferritin levels can indicate severity. Is there another mnemonic for that? Ferritin flags.
Ah, yes, let's try that. Ferritin level guise management. Less than 1,000 GL, or about 2,250 pmols using the other units, generally means low risk of serious liver damage. Though the notes mention thresholds like mild 1125, moderate 1125, 2250, severe 2250 picomoles L. Maybe simpler to focus on the 1,000 microgram threshold. Above 1,000 GL may prompt biopsy consideration. Greater than 1,000 is a key flag. Saturation, transferrin saturation is also key, especially early on.
Okay, so that 1,000 microgram per liter ferritin level is a key benchmark for potential liver risk.
It often is, yes, although decisions are always clinical, considering the whole picture. Below that, the risk of advanced fibrosis or cirrhosis is very low, less than 1% usually. Above it, the risk increases, hence considering biopsy or MRI fibrosis assessment.
And lastly, on investigations, how do you check if organs have actually been damaged?
Right, assessing end organ damage. For the liver, we use LFTs, MRI for iron and fibrosis, sometimes a biopsy. For the pancreas, a fasting glucose or HbA1c screens for diabetes. For the heart, an ECG and an echocardiogram, heart ultrasound, look at rhythm and function. For hormonal issues, we check sex hormones, testosterone, FSH, LH. And because chronic illness can affect bones, a DEXA scan might be done to check for osteoporosis. So it's a package. Labs, genetics, imaging, maybe biopsy, all tailored to the patient.
Okay, comprehensive workup. So let's say we have a confirmed diagnosis of hemochromatosis with iron overload. How do we manage it? What's the treatment?
The absolute cornerstone of management is getting that excess iron out of the body. And alongside that, providing genetic counseling for the patient and their family is crucial.
And getting the iron out usually means bloodletting, phlebotomy.
Exactly. Venesection, or phlebotomy, is the first-line standard treatment for hereditary hemochromatosis if there's iron overload. It's basically removing blood regularly, just like donating blood.
And how does that work? What are the targets?
The goal is to lower the body's iron stores. We monitor this using ferritin and transferrin saturation. The usual target is to get ferritin levels down to the lower end of the normal range, typically below 50 micrograms per liter, and keep transferrin saturation below 50%.
What if someone can't have phlebotomy? Say they're severely anemic or have major heart problems.
Good question. It's less common, but if phlebotomy is truly contraindicated, then we move to second-line treatment, which is iron chelation therapy. That uses medication to bind the iron so it can be excreted. Desferrioxamine is one drug used, often given by infusion.
Okay, let's focus on phlebotomy since it's the main thing. What's the usual schedule? There was another mnemonic, phlebotomy plan.
Right, let's unpack that. Prior assessment, always check for complications before starting. Hydration is important. Tell patients to drink plenty before and after. Less strenuous activity right after the procedure. Every 1 to 2 weeks is typical for the initial phase to get the iron down.
Okay.
Blood removal is usually 1 unit, about 500 milliliters, which takes out roughly 250 milligrams of iron each time. Objective is that low ferritin, under 50 LEL usually. Transferrin saturation target also, under 50%. Ongoing maintenance therapy is needed lifelong once targets are reached. Monitoring ferritin and sat regularly is key. Yearly review is generally advised, maybe more often depending on the situation.
That's a clear plan. So weekly or biweekly at first, then less often for maintenance.
Exactly. Once the iron levels are down in the target range, the frequency drops right down, maybe needing venesection only every 2, 3, or 4 months, just enough to keep the ferritin below 50 OGL. It varies between individuals.
And you mentioned assessing for complications first.
Yes. Essential to see what damage might already be there. And importantly, even if someone's symptoms like joint pain don't improve much with phlebotomy, you still continue the treatment to prevent further iron buildup and potential worsening or new complications.
Right. What are the main benefits people might see from phlebotomy, and what doesn't it tend to fix?
Well, the big benefit is removing the iron, which stops further damage. It can often improve fatigue, sometimes skin pigmentation, maybe liver enzyme levels, and potentially insulin sensitivity if diabetes isn't fully established.
Okay.
But it generally doesn't reverse established cirrhosis, unfortunately. It also usually doesn't reverse hypogonadism or significantly improve established arthropathy, the joint damage. Those often persist.
So it stops progression, might help some things, but doesn't fix everything once it's damaged.
That's a good summary. And as a general measure, we often recommend hepatitis A and B vaccination for anyone with chronic liver issues, including hemochromatosis.
What if someone has progressed to end-stage liver disease? Is transplant an option?
Yes, liver transplantation can be a life-saving option for people with liver failure due to hemochromatosis cirrhosis. The outcomes might be slightly less good than for some other causes of liver failure, possibly due to the effects of iron in other organs, but it's definitely considered.
How are patients monitored long-term during treatment? You mentioned ferritin.
Serum ferritin is the main thing we track to guide the frequency of maintenance phlebotomy. As we said, keeping it low, ideally below 50 NGL, is the goal. We monitor it regularly, maybe every few months initially during maintenance, then perhaps less often once stable. And remembering that ferritin over 100 DL benchmark for considering liver biopsy or fibrosis assessment if it wasn't done initially. And if someone does have cirrhosis, they need regular screening for liver cancer, usually with ultrasounds.
What about pregnancy? Any special advice for women with hemochromatosis?
Yes. Generally, women with HFE hemochromatosis should avoid taking routine iron supplements during pregnancy unless they're actually shown to be iron deficient.
Okay, no extra iron unless needed.
Right. Their ferritin levels should be monitored during pregnancy. If they do become iron deficient, treat it normally. If they have very high ferritin levels before pregnancy, therapeutic phlebotomy is usually deferred during pregnancy itself, and specialist input is definitely recommended.
Makes sense. What about diet? Do people need to avoid all iron-rich foods?
That's a common question. Actually, the most important thing by far is sticking to the phlebotomy schedule. Diet plays a secondary role.
Okay.
We generally advise avoiding iron supplements or multivitamins containing iron. Some people suggest avoiding heavily fortified cereals. Drinking tea with meals might slightly reduce iron absorption, but the evidence isn't super strong.
What about vitamin C? I heard that increases iron absorption.
It does. So we usually advise limiting vitamin C supplements to maybe less than 500 milligrams per day and perhaps not taking them with meals. And definitely avoiding excessive alcohol is critical because alcohol and iron are a bad combination for the liver. But a super strict low iron diet isn't usually necessary if phlebotomy is being done effectively.
All right, phlebotomy is the heavy lifter. And if someone can have phlebotomy, you mentioned chelation drugs.
Yes. In those specific cases where phlebotomy is contraindicated, medications like desferrioxamine or oral agents like deferriaserox can be prescribed to bind and remove iron. That's managed by specialists.
Okay, so summing up the non-drug management. Regular phlebotomy is key, sensible dietary adjustments, but not extreme restriction, and making sure genetic counseling and family screening happen.
Exactly. Tailoring the intensity based on their iron levels and stage.
So what's the long-term outlook? If someone gets diagnosed early and sticks to the plan, what's the prognosis like?
Generally, it's very good. If diagnosed before significant organ damage occurs, and if they manage their iron levels effectively with regular phlebotomy, most people with hemochromatosis can expect to live a normal lifespan, pretty similar to the general population.
That's really encouraging. Are there still some risks, even with treatment?
For those who are C282Y homozygous, even with treatment, there might still be a slightly increased lifetime risk of developing liver disease, particularly cirrhosis and potentially hepatocellular carcinoma compared to someone without the genes. But the absolute risk of severe liver damage if treated early is thought to be fairly low, maybe around 5% in men, and even lower, less than 1% in women.
Okay.
But if someone already has developed cirrhosis or liver cancer by the time they're diagnosed, then obviously their prognosis is more serious and life expectancy can be reduced. So the key message from observational studies is early diagnosis and adequate timely treatment lead to the best outcomes.
Right. Early detection and sticking with the treatment are paramount. What are the big complications we're trying to avoid by treating hemochromatosis? What happens if it goes unchecked?
Untreated, the continuous iron accumulation can lead to really significant organ damage. The main ones are liver cirrhosis, which carries the risk of liver failure and liver cancer. Heart problems like cardiomyopathy leading to heart failure or arrhythmias. Diabetes mellitus from damage to the pancreas. And potentially an increased risk of other cancers too.
Are these complications reversible once they happen?
Some are potentially reversible, at least partially, with iron removal. Cardiomyopathy can often improve significantly. Skin pigmentation usually fades, but others, unfortunately, are generally considered irreversible once established. This includes liver cirrhosis, fully developed diabetes, hypogonadotropic hypogonadism, and the joint damage, the arthropathy.
So you really want to prevent those irreversible ones.
Absolutely. That's the goal of early diagnosis and consistent management, prevent or at least delay those serious permanent complications. And just a final point. Occasionally, people present with all the classic features, the iron overload and organ issues, but don't have the common HFE mutations. So clinical suspicion remains important, even if genetics are negative initially.
Understood. Well, this has been incredibly thorough, a really helpful deep dive into hemochromatosis.
Hope it's been useful.
Definitely. So the key takeaways, it's genetic, involve too much iron absorption. Early diagnosis is absolutely vital to prevent potentially irreversible damage, and regular phlebotomy is really the main treatment.
That's it in a nutshell.
And also, just how common it is, relatively speaking, especially in certain groups, makes you realize why awareness is so important for everyone, public and clinicians alike.
Absolutely. And it does lead to a broader thought, doesn't it? For you listening, if we have a condition that's genetic, relatively common like this, and treatable, especially if caught early, what does that mean for the potential role of, say, wider genetic screening or more targeted population screening? Where's the balance?
That's a really interesting question to ponder. Food for thought.
Indeed.
For anyone wanting to dive even deeper, or maybe test themselves on this, definitely check out the resources at pathomsra.com and also freemsra.com. Lots more there.
Great resources.
Thanks again for joining us on this deep dive.